Hello, good evening. And first, a small correction. Session 17. All right, so welcome to session 17, spleen and pancreas, right? We'll be taking two topics. Now, what we see over here is this can be utilized for practice. Otherwise, at the end of this PDF, there is one more image for the practice. So after learning the entire spleen and pancreas properly, right, we'll be going through this image. This is the CT scan at the level L1, and that's where we'll be identifying all the components, right? And then there'll be one other image which will be unmarked, and that would be for your practice. So even this image can also be utilized for practice. Okay, sorry. So let's start with spleen first. It's also called as spleen, right, in Greek, but we are interested in this Latin. I take a break for just 1 minute. I get water and come back. Just within a minute, I come. Okay, sorry. So in Greek, this is spleen, and in Latin, it is lien, right? So that's why that ligament was linorenal ligament related to spleen and kidney. Okay, so this spleen is in adult, it is like a lymphatic organ, right? Though in childhood, it is acting as a hemopoietic. So it's something which is forming the blood, hemopoietic organ. In adult, it will be taking the function of this lymphoid organ, plus it will be used like say filtering the blood. Only in cases of emergency, that is in case if there is massive bleeding, so then spleen can act as a reserve supply, right? It can act as a reserve supply. More as we proceed. But one important thing that it is very vital for our immune system. Now with this, say there is so much of confusion about actually the shape of spleen, right? Why it is said that it is like a triangular pyramid. No, it's like we keep on imagining that, okay, triangular pyramid. And so what I thought is, say this is like my one of the cube, right? Not cube, but this is triangular pyramid, right? So this is, if we consider that it's a base, and with that base there are three sides, one, two, three, right? There are three sides. So it means this entire structure will be having four surfaces, one which is at the base, and these three on the other side, right? On all the sides. Now spleen is on the left hand side. So when we think it like this, that say this is the surface which will be associated with the diaphragm, and then that's the direction, right? This is the pointing surface. So in other words, if we keep our hand like this, right? So that's the anterior end, and the posterior end will be above, right? More as we proceed. So in shape, we'll be telling it as, it is technically called as the tetrahedral, right? Tetrahedral. So it means it is triangular pyramid, and as we saw that it has got four surface. Fine. Because all these surfaces, every border would be properly defined, that okay, this is the meaning, this is the meaning, etc. Right? So like that's the base, and then it is pointing in air, right? It is at one point, all of them, they are meeting. So that's how this tetrahedral comes into picture. Fair enough. Okay. So that's the spleen, right? Right side, left side. Now for spleen, it said that you can remember it like 1, 3, 5, 7, 9, 11. This is dimension, this one is weight, and this is its location. So 1, 3, 5, that means this you have to take in inches, right? You have to take in inches. So 1 by 3 by 5 inches. 1 is the thickness, right? Then the width and the length. So this width is, this one is 3 inches, and the length is 5 inches. So that is 1 by 3 by 5. And we can always see that this is left hypogastrium, right? That is where hypochondrium. Yeah, right. Hypochondrium. And this is epigastrium. True? So that's the location, how it is arranged. Regarding the weight, this weight is in ounce. So it is 7 ounce. Now 1 ounce technically, I mean, if you want to be very specific, it is 28.35 grams. But roughly, even if you consider about 30 grams, right? So that comes to about 200 grams, right? It would be actually less than, slightly less than, but this is roughly 200 grams. So that's the size. Interesting part is 911, right? Nothing to do with that 911, but this 911, these are the ribs. These are the ribs. It is between 9th and 11th rib. So 9, 10, 11, those are the ribs which will be associated with the spleen, right? So this location is between 9th and 11th rib. Function of spleen, that's what I said, that is for the immune system, right? In childhood, it is hemopoietic. That means it would be forming the blood, but not in the adult. All right. say this is the direction, this is the axis. So that's the 10th rib. So spleen is lying in this, right, at the axis of 10th rib, right, in the direction of the 10th rib. And the angle which it's forming, this angle, it is about 45 degree, right? So that's the 10th rib, and with the horizontal line, that's the 45. So it means that spleen is arranged at an angle, right? It is arranged at an angle. Anterior surface, that is lower, anterior point is lower, anterior end is lower, posterior end is higher, because it is arranged like this, right? So with your palm, when you do it like this, so that's the arrangement, right? Anterior is lower. We'll see even in our further scans. Okay, here it is. It will give much better clarity. So here we are watching it from the side. That means immediately you'll come to know that this is anterior and that's the posterior, right? So over here, here is the anterior end. That's the anterior end and that's the posterior end. So this posterior end is higher, right? That posterior end is higher. Now, obviously this is superior and this one would be inferior, and accordingly the borders are there. Okay, accordingly these borders, this is the superior border and that's the inferior border. So this is the superior border, and this superior border would be notched, right? You can see those notches, these are notched, right? So they are notched. Regarding this inferior border, that is pretty smooth. Rest all are ribs. Okay. Now if we talk about surfaces, from this point onwards, you need to imagine a bit, but it is not very difficult. See, if we draw, so then that's the diaphragm, right? So we draw the diaphragm like this, right? The spleen is arranged like this. It means there is one surface which is in close approximation with the diaphragm, so that is smooth. And then there is another part over here, which is called as the visceral part, right, or the visceral surface. So this is not smooth. It would be irregular, as it will be associated with so many organs. So today's session is like, but you have to be completely clear that how exactly spleen is arranged with respect to other organs, because it will be comprising of pretty, say, good number of structures, right? So here it is. One is the diaphragmatic, and this is completely uncomplicated because that's the portion. It is convex, smooth. It has to be, right? But the second portion is the visceral, and this visceral is irregular. Irregular. Now, when we'll draw the spleen, we'll find that it is something like this, because this is the portion which is also called as the hilum. It is through hilum all those vessels will be going, right? So that's why we'll also add one more word, and that is the concave. This is concave and irregular. That one is convex and smooth, right? So far, all easy. Okay. Now, if we see that this spleen will be involved in many of the diseases and its size is going to increase, right? And that is, if spleen increases in size, so then it is called as the splenomegaly, right? Splenomegaly. If it is liver, it is hepatomegaly. So splenomegaly. Now, in such cases, spleen is to be palpated, right? You need to palpate the spleen. So for that, you need to know that which is the area which is most forward. Obviously, this lower end, right? This lower end, that anterior portion, that is the most forward. So anterior end, that is most forward, correct? Most forward. So when this anterior end, right? This anterior end, that's the anterior end, and along with the superior border which we already saw that it is notched. This part is what is called as the enterobasal. Enterobasal. And this is the region which can be palpated when the spleen is enlarged. Right? And this is the reason it is also called as the clinical angle. Clinical angle of spleen. Right? So that's the clinical angle of spleen. You'll find it when the spleen is enlarged. Now, right? This is stomach, and that would be the duodenum, right? And when we draw it like this, so this would be pancreas, and that spleen, right? Those dotted means they are just behind the stomach. So actually this would be the relation. This is how things would look like, right? And as we said, the hilum part. So this would be the hilum. This is hilum. This hilum is where it would be pierced by all the branches and tributaries of splenic vessel, right? So this is where the diaphragm would be there. Diaphragm, diaphragmatic surface, and that's where the splenic vessels, they will be entering. So hilum, we'll just write one word. It is pierced by splenic vessels, right? Branches and tributaries. Very conceptual diagram, right? This is for the peritoneal relations. This is for all those peritoneal relations. And we see two things first. One, the gastrosplenic ligament. This one. That is first. To see this gastrosplenic, see, we go back to what we drew over here. Here it is. That's the stomach, and this one, this is the stomach, and that's the spleen. So at hilum over here, that would be the gastrosplenic, right? Same thing when it is seen over here. So that is gastrosplenic, right? This would be the location. This is the gastrosplenic. And another one, that is the linorenal. Now sometimes it really happens that all these schematic diagram, they do create some confusion, right? Don't worry, we'll be having several images, so it will be completely clean. But this is important because we need to know three peritoneal reflections, right? Three peritoneal ligaments. One was gastrosplenic, second is linorenal, and third is phrenicocholic. Now phrenicocholic, that is between diaphragm and colon. So what it is doing over here, it just supports. It is just for support, right? So that's the thing. It just supports. So we now know 3 peritoneal reflections. Now saying gastrosplenic ligament, why it is important? Because it is from greater curvature of stomach to hilum of spleen. So it is going towards hilum of spleen. Okay. Same thing. Just a minute. See, this is error, right? It has to be. It is not lineorenal, right? It is linorenal. L-I-E-N-O renal. Linorenal. Okay. That contains tail of pancreas and splenic artery. Tail of pancreas. Right? We'll see that in case when there is splenic rupture, for some reason, if there is splenic rupture, it bleeds heavily. So one has to go for splenectomy. You need to remove the spleen. When you need to remove the spleen, it means you have to cut down all those ligaments. During that process, you need to take utmost care for linorenal ligament, because if that is not taken care of, then tail of the pancreas is sacrificed. When the tail of pancreas is sacrificed, we'll see during our discussion of pancreas that it contains islet of Langerhans, and most importantly the beta cells, right? Those beta cells which are making insulin. So if that is sacrificed, immediately for rest of the life, person will be diabetic, right? So that's the reason it is so important to know these structures. So in gastrosplenic, which is from hilum to greater curvature of stomach, what it will be carrying? Well, it would be carrying short gastric vessels, right? Plus lymph nodes, and some sympathetic nerves, right? But in this, you need to know about that, okay, those are the short gastric vessels. They will come in the blood supply, will make that completely clear. So this is one. We are interested in this linorenal because it is tail of pancreas. That's why clinically it is more important, right? Okay. See. So that's the spleen, right? This one is spleen. And spleen is associated with those ligaments, right? And in these ligaments, there are two. One is the gastrosplenic and second is the linorenal. Now, linorenal, right? Linorenal between the kidney and the spleen, that is, it in its content is the tail of pancreas. So that is the tail of pancreas, right? And pancreas and spleen are at the same parallel level? No, not at all. Right? They are not at the same level. They are definitely at an angle. So that's why in CT scan, you will see that shape of the pancreas, it won't look like the way we are drawing because it is like an angle. So wherever, when you do the CT scan, it is like it will be cut at various angles. So that's the reason that shape of the pancreas will keep on changing. You got the idea? Right? Because if it is like this, right, and when we cut it like this, so its shape would change. Good question, right? There is little antro-posterior relation among them. Exactly, very right. And what we were talking about was that when you do splenectomy, you need to remove the entire spleen. So that means you have to cut down all those ligaments also. During that process, when you cut down linorenal ligament, right, and if the care is not taken, that to separate the tail of pancreas, so that tail of pancreas is consisting of islet of Langerhans, right? And today we'll be watching even the histology also. So at that point we'll discuss it in bit more. But these islet of Langerhans, especially the beta cells, right? Because alpha cells, they release glucagon. So these beta cells, they secrete insulin. And if the person is devoid of insulin, trouble, right? This is like, then he would be diabetic for rest of the life. That's the reason it is vital. And these are some very important keywords. So do remember this part. Right? I hope it is clear. Okay. And the third one was phrenicocholic, right? So in phrenicocholic, it is just for support. Fine. No, this is better. See, stomach, good, right? Just underneath the stomach, this is spleen, right? And at a lower edge, yes, there is descending colon, right? And the left dome of diaphragm, which is on the back side, right? And same thing, if when we'll see it in the form of cross section, right? How it would look like, say this would be the diaphragm, right? And spleen is like a wedge shaped tetrahedral. So that would be the spleen. Kidneys, they will be retroperitoneal. So here would be the kidney, right? In between, this would be the lienorenal ligament. The stomach, that would be in front because spleen is behind the stomach. So this is anterior, right? By the way, this is anterior, this is posterior, just for the clarification. And here would be the stomach. So with stomach, yes, there would be gastrosplenic ligament, right? This entire area is hilum, correct? It is hilum. So that's for the clarity. This is how they are arranged, right? And over here we are watching it in a different plane, right? Now stomach, it is important because it is the largest. This is the largest and most concave. So when you'll see the visceral surface of spleen, right, there would be one big area, but that biggest area is because of stomach. So don't forget, that's why we are putting it as number one, right? So whenever you are given the spleen in your hand, you'll find one area is completely smooth and the second surface, this is concave. In that concave, the biggest area, that is 100% fundus of stomach, right? Done. Okay. On the lower side, the smaller one, that is the descending colon. So these are some visceral relation. Adding something more to that. So that is, so we saw two structures, one which was stomach and second was that splenic flexure, right? So we saw this. So I'm marking over here as 2. The third thing which you see is the left kidney. Now see how finely it is arranged. So this would be another important structure after the stomach, right? Because that splenic flexure would be imparting a very small image. So one largest one is stomach. The second which you see, that is the left kidney, right? That is the left kidney. And here is the pancreas. This one is pancreas, and see how it is going. And then this is tail of pancreas, right? This is tail of pancreas. That's what you see into its hilum, right? So that's the tail of pancreas. So these are the important structures. What would be going inside the hilum? Well, these are the splenic vessels, which we'll be discussing and we'll be watching it more detail. But over here, just the splenic artery and the splenic vein. Splenic artery is traveling just above the pancreas, right? And splenic vein is underneath, right? I'm so sorry. Just a minute. This image is telling one important point. This spleen is a very friable organ, right? Spleen is friable. Friable means it can break very easily, right? It can literally break down into pieces. Its importance is that, let's say, sometimes we need to put the needle into spleen. Many reasons, whether you want to take the pressure, or you want to take some biopsy, so many things, right? But that's what it is, that if the needle is to be placed, needle in spleen, right? So then first thing you'll tell to your patient, hold your breath, right? Stop breathing for few seconds, because spleen moves with moves with respiration, right? And when the needle is there, so then this needle, it can literally cut down the spleen, right? It can lacerate. So that's the reason I'm happy that your anatomy fear is gone, right? And yes, very soon we'll be starting with the physiology also, right? Because I got, just in last 2 days, I got almost nine or 10 mails about the physiology. Yes, very soon we'll start, very soon, right? So this is to prevent laceration. Lacerated means just the cut. All right. Now comes our arterial supply, and trust me, you know it so well. You really know it so well. So actually, there is no need. What I am doing right now is just a sort of revision, because I know that you know it very well. So we start with what? Celiac trunk, right? In celiac trunk, there is a tortuous one which is going, none other than splenic artery, correct? That splenic artery will going all the way, right, into the hilum, when it is going into the hilum, it should be going into one ligament, and that ligament we have talked about it. It is lino-renal ligament. So do remember this part, right? This is lino-renal. So highlighting it, and it goes. Done. During this course, it will be giving few branches. So we need to know about the branches of splenic artery. Branches, they are all very sensible branches. They say that who is near, right? It'll say pancreas will straight away say, okay, I am near. All right. So pancreas, they are given few branches. They are called as the pancreatic branch, right? So pancreas, they are getting few branches. Then there would be short gastric branches. So stomach is the next candidate. And then there is left, this is interesting, and we know this left gastroepiploic, right? Left gastroepiploic artery. Long name, so that means it will be forming that arcade on the greater curvature, right? Now we know this part, right? So over here, left gastric, right gastric, right? Short name, so lesser curvature. Greater curvature, left gastroepiploic, right gastroepiploic, and that is at a greater curvature. True. Now this left gastroepiploic, that is from splenic, right? How about right gastroepiploic? That would be the branch of gastroduodenal, correct? Gastroduodenal. We'll see that. Because that gastroduodenal will be divided into superior pancreaticoduodenal, and then right gastroepiploic, and then from superior mesenteric that inferior pancreaticoduodenal will come, right? We have talked about it, but still we'll see it. Okay, here it is. See, right? So we just say this is, quickly, this is celiac trunk. From celiac trunk, there goes this common hepatic artery. Yes, that is true. Then there is left gastric. Yes, and then there is this splenic one. So it is in this order, it is done. Now, this splenic, it is giving those pancreatic branches. Yes, because that splenic artery is right now in focus. So we are not talking about others. So this is done. Then it is giving few branches to say spleen. It has to, and then the entire pancreas to the body. So that means it is magna, bigger one. So this is arteria pancreatica magna, another way of telling that big artery to the body, and cauda, tail, right? And this is tail of pancreas, so it is giving a small branch to that. So that is the caudal branch or the tail branch. Done, finished. Now coming to this part. This is the proper hepatic artery and this is the common hepatic. Common hepatic, it divides into this gastroduodenal, right? So we were on number 7. So let's put number 8 over here, right? Proper hepatic, it is going into liver, let it go, right? And this gastroduodenal is dividing into the superior pancreaticoduodenal artery. So that is number 9. And it meets that inferior pancreaticoduodenal number 10, which is branch of superior mesenteric artery, right? That is number 11. This is again that image which you should draw, right? You should draw. Once you draw and try to draw in the same order, you draw it 2, 3, 4 times, then it will come into your second nature. You will never miss anything. Okay. All right. Next is, now we are talking about that what really happens, because in splenic circulation there are so many mysteries. That this is splenic artery, it is okay. We saw that it is divided in all those branches, right? Those branches, they divide, they do divide more, so there are more divisions, right? There are more divisions, and finally now they land in what's called as a straight vessels. Straight vessels. They are given name, right? It is called as penicilli. Straight vessels. And then they will be entering into ellipsoids, because entire spleen is divided into these ellipsoids, right? And finally the arterial capillaries. So those straight vessels, then they form curved, and then finally they become those capillaries. But then what happens to those capillaries? That is where the theory of splenic circulation comes. In simple words, from spleen to artery, that's okay. These are the names, penicilli and ellipsoids, means they are like, because of the architecture of spleen, yes, they divide it like that. But now from this point onwards, what happens to these capillaries? This question would not have arrived for any of the other organ, because things are pretty clear that okay, these are the arteries, they divide, and they form those capillaries, and these capillaries, right, they will be supplying to the tissues, and then they all will unite again, and finally it will lead to formation of vein and circulation continues. Here there are pools. So there are two theories, right? Two theories. Up to capillaries, no complication. But over here, one theory is what is called as the open theory. In open theory, it tells that these capillaries, right? So why I'm writing again, when it is these capillaries, right? They open into like a swimming pool, right? They open into a pool, and name of that pool is red pulp. Red pulp. So straight away they will land into that and they will put their blood into that. And then from here it will go into those sinusoids. Sinusoids means once again they will start collecting the blood and then it will go back. So that's why it is called as the open theory, that where every capillary will come and then will put their blood into red pulp. ठीक. what about the second? If this is open, then there has to be a closed theory, right? Yeah, actually it is. So this closed theory tells that these capillaries, they will go into venous sinusoids. That means the red pulp is there, right? That swimming pool is there, but in that swimming pool there are several pockets. And these capillaries will be draining into those pockets, and those pockets, they are called as the venous sinusoids. Venous sinusoids. And these venous sinusoids, they are in red pulp. You got the idea, right? Over there in open theory, it was telling the entire swimming pool just dump, everyone would dump, and then it would be collected. They say no, over here in closed theory, there are specific pockets. In that, all those capillaries, they are opening, right? And then from venous sinusoids, all those veins would be formed and it would be carried. The interesting part is that they are not fighting. No problems. And that is what is called as the compromise theory. How interesting. Right? Compromise theory. That when the spleen is distended, right? When the spleen is distended, so then let's put the open theory. And when the spleen is contracted, so then it is closed theory. Right? So that's how the controversy has been settled. Now, in case of spleen, there are two planes. Right? This is important. Superior, so that's why another one would be inferior. Yes, they are superior and inferior vascular segments. Superior and inferior vascular segments. So there is a thin patch in between, and that is what is called as the avascular plane. So if you put any incision over there, right, avascular plane, because spleen is with rich blood supply, but in this avascular plane, a small plane in between, right, if the cut is put, so then it will be like a bloodless thing. Okay. For the venous drainage, not complicated at all if you just understand that how the veins are formed over here, and nothing can be simpler than this, because it is like this is superior mesenteric, right? Superior mesenteric vein, and splenic vein comes from here. This is superior mesenteric vein, and they go into the portal one, right? So into the portal. And where is inferior mesenteric? Well, inferior mesenteric will come and join the splenic vein, right? So easy and so good. But so venous drainage is exactly like that, right? You are watching superior mesenteric vein, right? Don't worry about this uncinate process, etc. We'll see that. Or to put it into simple words, this is like entire this pancreas is divided into this uncinate process. Then there is head, then there is this is head, this is neck, that is body, and finally the tail, right? So that is like that. So over here, superior mesenteric vein, right? That is good. Then this one is inferior mesenteric vein. Yes, this is fine, and this one is, say, this one is splenic vein, right? And it meets, and they meet to form that portal vein. From splenic, right, in draining into the splenic vein, these are the pancreatic veins. See, indirectly, what everyone is trying to do, they are telling that, see, these short gastric veins from stomach, right? From spleen, this is already a splenic vein. Pancreatic vein, they will say, okay, from pancreas, they will be draining into it. The idea is send everything to liver. So superior mesenteric taking care of midgut, right? Inferior mesenteric vein taking care of hind gut. This splenic is taking care of the foregut, right? It is taking care of that foregut. And whosoever is near, they will be draining into any of these three veins. And finally, everyone is sending it to liver. Okay, jao liver, now you work, right? Because liver is what we'll be doing for this detoxification and all those processes, right? So that's how the venous drainage of spleen. Very simple, straight away via the splenic vein. Okay. For the nerve supply, just one word. Just one word. The nearest is celiac plexus. Right. And I told you that we'll be learning all the plexuses in one session. Right. So this is like celiac plexus. You'll be getting it. For the functions of spleen, right? Now when we talk a bit more about it, one of the function, right, that is the phagocytosis. This is the reason that whenever there is large amount of breakage of those RBCs, maybe because of, say, those cells are immature, or those immature cells, they are available in large number, so spleen tells that I need to take them off, right? Which branch of superior mesenteric vein supplies spleen? See, superior mesenteric vein, right? First thing is, say it won't supply. When we are talking about vein, right, it won't supply, right? It would drain. Right? Supply is by arteries, right? Supply is by artery. So I'll draw over here and then I'll erase it, right? So if you're talking about, say, superior mesenteric vein, right? And over here there is a nice splenic vein. So here spleen would be sending its blood via splenic vein only. Why it should need even superior mesenteric vein, right? Because from here it will go to the portal. So that's it. This much is needed. Superior mesenteric vein as such directly won't touch the spleen. Why not? Because superior mesenteric vein is draining which gut? It is draining midgut, right? And when during the development, right, I'll just take you to that, when the gut was here, right, there was dorsal and ventral mesogastrium. So you remember we drew it like this, right? So this was the dorsal mesogastrium and this was the ventral mesogastrium. Then in dorsal mesogastrium, there was small area which developed, and that was what? That was spleen, correct? That was spleen. And all these things, they are like foregut. It means it is the foregut. It is the foregut in which spleen is there. Now spleen, if it is in foregut, so then there is a specific artery and specific vein which is for foregut. When we talk about the artery, so for the foregut, the artery is celiac trunk, correct? It is the celiac trunk, because celiac trunk is giving the splenic artery on this side it is giving hepatic, and on top of it giving left gastric, right? Gastric, because stomach is also a part of foregut, right? Up to D1. Then starts the midgut. So for midgut, so we have got a special one, but this midgut is starting from D2 to all the way up to that transverse colon, the first 2/3, right? So then it will be taken care of, that part. So over here, technically, if you see, it won't come, right? So you got the idea? So why I explained it? Because your question, which is telling that which branch of superior mesenteric vein, when we say branch, that means it has to be superior mesenteric artery, That is one. When we talk about vein, so then veins, they have got tributaries. Tributaries means those tributaries like Nadi, right? So they come, all those streams, they meet and then they become a big stream. That's what really happens in case of veins. So in case of veins, they are called as tributaries. Branches, they are for arteries, right? When we say supply, right, supply means it is giving. It means from heart, the blood is given to that organ. So that means we are dealing with artery, right? When we say about the vein, so veins will do drain, right? So I would correct that statement like that, which tributary of superior mesenteric vein would drain spleen, right? If the question is to be asked, right, so it has to be asked like that. Right? Answer, none. Right? Because superior mesenteric vein is handling midgut and spleen is not at all a part of midgut. Why not? Because spleen is getting developed into the dorsal mesogastrium. Right? Dorsal and ventral mesogastrium, they are the classical things for foregut. Right? In midgut and the hindgut, as you saw, that you won't find two mesogastrium. Right? I hope I'm clear. All right. So let it remain, right? We just add one more page and we'll continue with that. Just a minute. Okay, all good. So we were talking about that what are the functions, right? What are the functions? So one function, that is the phagocytosis. It is because of this phagocytosis, it eats up, right? And that leads to that unconjugated bilirubin. And that unconjugated bilirubin, liver is unable to handle this much of load. So that's why that unconjugated bilirubin, it goes into the stream and which gives yellowish hue, right? Which gives yellowish hue. This is what happens in non-obstructive jaundice. Right? All those things, they will be coming still in more detail when we'll be discussing the liver. Okay, then this is hemopoiesis. Hemopoiesis, do remember, it is in only in childhood, right? Only in childhood. Then for the entire life, it is what is called as the lymphopoiesis. So it will be handling all those lymphatics. So this is for whole life. That's for whole life. And fourth thing is, this is acting like a storage of RBCs, right? It is acting like storage. So in case if there is an emergency, so it will be supplying, right? Supply in emergency. And obviously, it is part of the immune response. Right? It's part of the immune response. So these are the classical functions of the spleen. Okay, for the histology. See, there are two pulps. One is red pulp, second is white pulp. Right? What are these pulp? Simple as this. Marpigian corpuscle, right? Only the name is big. Otherwise, there is nothing special. Watch for first the capsule, right? This is one. What this capsule? This is the outer covering, right? That's the capsule. Now this capsule is fibroelastic tissue, right? It is, why it has to be fibroelastic? Protection, right? So it is a fibroelastic tissue. There are smooth muscles in it, right? So we'll say smooth, with smooth muscles. Okay, so that part is done. Now, as we said, that red pulp is like a pool. So over here, this is, just imagine this entire thing is a pool. What red pulp is? Red pulp is nothing but it is collection of cells. All those cells, right? And they are in between those sinusoids. So it means over here, the only thing which is seen is, right, in between sinusoids. And as we said that spleen is divided into such small pockets, right? And all type of cells, all those collection of cells. Now it would be having RBC, it would be having WBC, it would be having all those lymphocytes, right? It would be having platelets, it would be having those, right, gobblers, right, macrophages, all type of cells are there. So in that open theory, the blood is simply dumped into that, done, right? So that is red pulp. What white pulp is? This white pulp is that these are the lymphatic nodules. So all these Malpighian corpuscles with eccentric arteriole, nothing more that here it is the artery, this one is the artery, and surrounding it these are the lymphatic nodules. But that's it. This entire thing is called as the Malpighian corpuscles with eccentric arteriole, right? I don't know why such complicated name, but putting in simple words, it is just lymphatic nodules around arteriole, right? And that's the white pulp. Okay. Yes, hemopoiesis only for childhood. That's right. Is graveyard of RBC and storage of RBC mean stem? No, no. Yeah, actually it is like this. So then what I would say is that it is graveyard for those bad RBCs, right? And it is house for good RBCs, because good RBCs they are stored and those bad RBCs they are slaughtered, right? So it is graveyard for those immature, improper RBCs. So they are slaughtered over there, right? And if the RBCs are good, so they are given good homes that you stay here and will send you to circulation as and when needed, right? So it is both. Actually, I do write all your ideas so that next time whenever I will be taking lecture, I use all those, right? I've got one idea book, so in that I keep on writing. So thank you. Okay. This that we talked just about that spleen, it develops in the dorsal mesogastrium, correct? Dorsal mesogastrium. And we have talked more and in detail about it, I think in the first or second film. That is for that foregut. You know? Right? This is the foregut. Now, this happens in the 6th week of intrauterine life. 6th week of intrauterine life. But this is when things are going very good, right? Spleen is not developing as a single organ, right? All those splenic nodules they develop and then slowly and gradually they fuse. Means that's okay. They will all be present into the dorsal mesogastrium, but then as they become bigger, they fuse. So those number of nodules, right? When they fuse, so it is a normal spleen. And if they don't fuse, right, for some reason, if they don't fuse, so in that case, they will be all scattered. Whenever such scattered things are there, they are called as the accessory spleen. Accessory spleen. In certain condition, if the spleen is very destructive, you feel like that, okay, we need to tell spleen to, okay, get lost, right? You don't break those cells. So you do splenectomy. But then this big boss has gone, but his chelas, they are over there, those accessory spleen. They will keep on breaking the RBCs, right? So that is where the importance of these accessory spleen will come into picture. You need to figure it out. Are they present, right? Okay. Spleen, it can give to that referred pain, that give to that referred pain. And in case of spleen, when it is enlarged, that pain would be on the left side, right? So that pain would be on the left side. So when there is splenic pain because of infarction, so it is called as the Kehr's sign. Kehr's sign. When it was over here, because of gallbladder that is on the right side, it was called as the Boas sign. It was called as the Boas sign. And the gallbladder was involved. Yesterday we talked about it. So that's how mild enlargement, moderate enlargement, and the severe enlargement. So this is where we are watching that enterobasal region, right? Or the enterobasal angle. That is what we see. Because that's the area which will be palpable. Yes. Liver, good, right? Then in front there is falciform ligament, that gunda ligament, right? Because of this shape, right? That falciform, that घास काटने वाला instrument is that falciform ligament. Parietal peritoneum, no wonder, because visceral peritoneum is always near to the organ. And this is the lesser sac, that's right. And over here we have got the stomach, right? Between the stomach and the spleen, over here, that is the gastrosplenic ligament. So this is good, right? Let's mark this. This is the gastrosplenic ligament. Then what? This is the greater sac, right? Rest of the area, all the intraperitoneal region apart from lesser sac is the greater sac, right? So that is the greater sac. And communication between them is, this is arrow that is in the epiploic foramen. And as you very rightly helped me, that epiploic foramen, which is on the edge of the peritoneum. So this is the foramen which is on the edge of the peritoneum. That's why it is called as the epiploic, right? That's the meaning of it. Okay, kidneys, they are retroperitoneal, so we see that. But the kidney which is over here, that is giving us one important clue about the linorenal ligament. So we have the gastrosplenic, we have got the linorenal, right? So this is so obviously that one is the spleen. This is the lesser sac. Why? Because it is just behind, the stomach. And this aorta and IVC, right? They are the evergreen structures which will always be able to appreciate even in CT scan, right? So these are the structures. A pain is there, so I think you are asking about that. Can that pain be cardiac also? Yes, that pain can be cardiac, because in both the cases it is on the left side. So from the rest of the history we have to really figure it out, that whether it is a cardiac pain or it is a splenic pain. Because when it is cardiac pain, the classical thing is that there is ghabrahat. There is no English word for that. Actually the word is ghabrahat, right? Whenever it is a cardiac pain, right, that pain which is associated with palpitation, which is associated with breathlessness, and then when the person really, that word itself is, because in our clinics they said it has to be, there is no problem, you can just write ghabrahat, that's the word, right? Because it actually depicts the entire situation, what really happens into this MI, right? Another thing, that when it is cardiac, that pain will not be restricted only to the shoulder, right? It will also go to the jaw, it can go to the back also, that is the tip of the scapula, right? That's where it can really go. Splenic, very much restricted. And in that, patient would be rowdy, patient would be shouting. Cardiac patient won't be shouting, right? Because they are actually, they say that word what I said, ghabrahat. Okay. For the splenectomy, That means it is a surgical removal, right? Surgical removal. And for the surgical removal, right, we need to take care of two things. One, tail of pancreas, correct? Tail of pancreas. So take care, right? Tail of pancreas, and that is where gastrosplenic and lienorenal, these are the ligaments, are to be taken care of because they'll be carrying some important vessels. Splenectomy, it can be done like complete, the entire spleen is removed, right? So and or it could be partial. Yes, spleen increases in its size. So in partial, one segment is removed. Interestingly, when we are removing complete splenectomy, so then those splenic pieces, right, spleen pieces of spleen, right, those tukras of spleen, they can be transplanted. They can be transplanted in, say, greater omentum, right, greater omentum, and from there, silently, they'll be taking care of our immunity. Right? They'll be taking care of the immunity. So this is doable. Okay. And regarding the splenic puncture, I told you that when you put the needle, take care, right? Tell the patient to hold his breath to prevent laceration. You remember we talked about portal hypertension, right? Portal hypertension. Now in portal hypertension, when the pressure is high, right? So there would be increased intrasplenic pressure, right? There would be increased intrasplenic pressure. So in over here, yeah, it has to be, right? That's the portal vein. This is the superior mesenteric. This is the inferior mesenteric. This is inferior mesenteric. This is splenic. So when the pressure is high over here, this is going to backfire everywhere. So that's where the splenic pressure, this would rise. And splenic venography can be done when you inject the dye and then you see the caliber and the vasculature, right? So that can be done. Okay, let's change gears now. Moving on to the much easier topic, smaller topic, that is pancreas. Pan means all and krias means flesh. This is completely soft, very soft lobulated organ, right? It is a soft lobulated organ. Two functions. It carries exocrine, it carries endocrine. That means in one case, there would be the ducts which will be draining directly into the organ, and in second case, endocrine, where things would be released into the bloodstream. That's the basic difference, right? Exocrine means they will be having ducts. Which duct are we talking about? Pancreatic duct. What it will do, it will create all those digestive juices, right? Digestive pancreatic juices. And those digestive juices, they will be drained into D2, right? Second part of duodenum. True. Over here, it will be generating all those hormones. Those hormones, say for example, insulin, glucagon, right? All of them, they are there. We are just writing insulin. And it will be put into the blood, right? And that's how it forms, right? Size 7 by 2 by 1. So it is a long structure, right? It is a long structure. So here it is, right? Dividing into 1, 2, this is D1, D2, D3, D4. This is the duodenum, right? That's the duodenum. But over here, that's the uncinate process. Uncinate means coma shaped, right? It is coma shaped. That is uncinate process. Then we have got head, neck, body, and tail, right? As if it is some animal. And then there is a small prominence that is tuber omental, right? There is a tuberosity sort of thing. That means it's a prominence, it's an eminence, and over there on that structure. Rest is that it goes into the hilum of spleen and everything is well known to you. Head of pancreas. In this all relations of pancreas, right, only two things are to be understood. Rest is all completely easy. Head of the pancreas, it is C-shaped. It has to be C-shaped because it is lying into the that C loop of duodenum, right? So it has to be C-shaped because it is lying into this duodenum. So that portion, this portion is head. That is head, right? Now this head, right? This head, this is superior. This one is inferior. And if it is superior, so here it would be D1, the first part of duodenum. If it is first part of duodenum, so D1, right? So it is first part of duodenum. So that means it is superior pancreatico-duodenal artery, right? I'm writing in short. So superior pancreatico-duodenal artery. That's right, coming from the top, right? This side is right, correct? Whenever we draw, so this is right, this is left, right? So from here, this is the area where there would be anastomosis, correct? So this from here, this superior pancreatico-duodenal would come, true? And from here, the inferior pancreatico-duodenal would come. So that's where the inferior pancreatico-duodenal artery. So that will come. And over here, there would be anastomosis. Fine. So here it is, first part of duodenum, then there is transverse colon because it would be in front. Superior mesenteric vessels. These superior mesenteric vessels, they are lying on that uncinate process, right? So this is a posterior structure. So that's how this first part of duodenum, the transverse colon and the jejunal loops, they are lying over it. And these superior mesenteric vessels, right? So that's the fourth one, right? So these are the all the anterior structure because our pancreas is posterior. So anterior structures. The important point which is to be understood. This is the only thing. Head of pancreas and what is lying behind. So over here we are watching the posterior structures, right? So these are posterior structures. Now all those posterior structures will be only those which are absolutely super big structures, which we just can't miss. Aorta, yeah, it is posterior, right? Big one. Aorta always with this inferior vena cava, yes, that is also a big one. This left renal vein and right venal vein, that's okay because in any case they are draining into, right? They are draining into the inferior vena cava. So that is fine. This is interesting because it is the bile duct. Why bile duct is here? We studied in that extra hepatic that it is this part which is going into the substance of pancreas, and then the fourth one which is intraduodenal, right, which will go into the duodenum. So that's the fourth part which we are talking about over here, but this part it is just embedded into the pancreatic substance, and that's where the pancreatic duct would come and meet, right? So that is again behind. Right cross of diaphragm, yeah, that is also behind. So, but main are the aorta and the inferior vena cava, right? Inferior vena cava, then renal and right renal, left renal, and this bile duct. So, main candidates aorta, IVC, and the bile duct. Okay. No more explanation is needed for the neck, right? This is for the neck of pancreas. In neck of pancreas, yes, that's the portal vein, right? This is the splenic vein, and that the superior mesenteric vein, they meet and it goes. So this neck has got some important roots where things are getting connected, right? So that's the portal vein portion. Okay, one figure and it tells so much. Celiac trunk, that is over there. This tuberomental, now you mean we know that it is that extra, like that oont, like a camel, there is hump. Root of transverse mesocolon, so that is there. But we watch this superior mesenteric vessels, they are classically coming it in such a way that they are behind the body but in front of uncinate process. Bas, that's the thing. So it is like, say pancreas is like this and they go like this, right? So like this, and you watch. How do I show? This one would be, so if this is uncinate process, right? So then those vessels, they are going like this. So this is the body, this is the body. So these vessels, they are behind the body and then in front of the uncinate process. But this you remember and understand very finely. But this part, right? Rest is all very clear that it goes into the spleen, this, that, right? Why to waste time? Okay. Here, few more structures are added so that it becomes clear. Say, aorta is all the way back, right? Or aorta is all the way back. So in this, we saw that superior mesenteric vessels, they are in front, yes, and aorta and IVC, they are on the back side, right? So this is another important. Superior mesenteric artery, that we already saw, right? That it will be in front of the uncinate process. Regarding this left renal vein, and say this would be the right renal vein. Right renal vein is smaller, left renal vein is bigger, because when we'll be watching that CT section, in that you'll see that left renal vein will curve all the way and will occupy a bigger area before it enters into the left kidney. That is what we'll see at a cross section, right? Because that would be the level, this would be the level when we'll see all these structures, right? So very important thing, right? Just keep in mind, and once you will see CT, and then I have kept unlabeled, you label it, done, right? You won't be committing mistake ever. Rest is all left kidney, splenic vein, we have talked so many times about it. Splenic vein, it is behind the pancreas. Splenic artery, it is on the pancreas, right? That would be, this would be over here when the splenic artery would be there, right? So hilum of spleen, we know you, thank you. This left suprarenal gland, well, we'll be talking about you in a specific session. Right now, it is just over there as a showpiece. Let it remain, right? Rest all good. Okay. Few names, right? Few names. This is like there is main duct, right? That's the main duct. And this main pancreatic duct, it is also called as the duct of Versung. Maybe some Chinese name or Korean name, I don't know. But this is the pancreatic duct. Main pancreatic duct is called as the duct of Versung, right? And then this accessory pancreatic duct, as if it's a girlfriend of this Versung, it is Santorini, right? Quite a feminine name. Right? So it is called as the duct of Santorini. I don't remember, but someone said, "Sir, doesn't it look like Santorani?" I said, "Ha, that's okay. That way you can remember." Right? Okay, so that's the accessory pancreatic duct, right? And finally, this is the bile duct. That's right, this bile duct will meet this main pancreatic duct of Versung, right? And they will go into the, so many names are coming over here, ne? Ampulla of Vater, you know, ampulla of Vater. And one more thing. And and over here there is a sphincter, right? There is a sphincter. And that sphincter is also given a name, that is sphincter of Oddi, right? Not this Oddi, right? Not this. It is just Sida Sada Oddi. So we have got four names with us. That accessory pancreatic duct Santorini, main pancreatic duct Versung. This bichara bile duct is simple bile duct, right? It joins this Versung, opens into ampulla of Vater, and say there is sphincter of Oddi, right? These are the valvular mechanisms. Those muscles, those circular muscles, they are called as sphincter of Oddi. Major duodenal papilla, this sphincter ampulla of Vater is also called as major duodenal papilla. And in case if there is accessory pancreatic duct, which is a smaller duct and it tries to open separately, so then we have got this minor duodenal papilla. Papilla means opening, right? You know this. Now you know this, right? No need for any of the explanations. Celiac trunk, then hepatic artery, common hepatic, then there is left gastric, then this is splenic, and these are the branches to splenic, and then there is pancreatic branch. This is for that tail, this is for that body, and here comes the superior PD, and this one is inferior PD. Inferior is a branch of SMS, supramesenteric artery. This is a branch of gastroduodenal. All done, good, happy. This is also easy, right? So for the venous, right? For the venous. Yeah, so many Ajib se names. And you will find such more Ajib se names when it will come to brain, right? Such cryptic names, you feel like it, what are they up to? But say in abdomen, the names are very happy names, right? They are not very cryptic, but they are happy names. See, Varsung and Santorini, and then that Santorani, and then we never forget. Right? Okay. So here it is, portal vein that is formed by the splenic vein, supramesenteric vein, and then this is inferior PD, and then the superior PD, splenic vein, all good, right? So this is the venous system. You know all of them. Good. Buffering? Really? Mm, is it okay? Is it buffering? Because now we are almost on the verge of that CT scan. So it should not buffer at that point. Just let me know if things are okay. Hope it's okay. Oh, so not buffering. All right. Okay. Okay. Regarding the lymphatics, right? They are so sida sada. Just in one word, they solved all the problem. Follow arteries. Right? Follow arteries. What a big relief, right? So these lymphatics, they are like pancreatico-splenic nodes. Then on the top, there are celiac nodes, right? And finally, superior mesenteric nodes, all so sharif, right? Just near all those vessels, and that's where they drain. Okay, okay. Nerve supply, nerve supply will be using our same style. Sympathetic, sympathetic, and parasympathetic. And the moment we talk about parasympathetic, boom, because it is we are dealing with foregut, vagus, right? And over here, these are all splanchnic nerves. What will they do? They'll say there is no need to work right now, so vasomotor, right? And or peristalsis, all those movements just inhibit everything. There is no need. No secretions, right? No need, so no secretions. When it comes to parasympathetic, you'll say, chalo, let's start the digestion process, right? So go for the pancreatic secretions, correct? And which would it be? Cholecystokinin and pancreozymin, right? So they are the important players will be taking part into this secretion, influenced by that. That's right. That's right. It is a vagus. And as it will be drained into the D2, and from there the rest of the processes would start. Now, though it has got nothing to do with anatomy, but it is important to know it, right? Regarding the functions, the first function, when we say digestive, in digestive, it would release trypsin. Because see, in our food, there is protein, there is carbohydrate, that is starch, and there are fats. So for trypsin, right, it will convert these protein into peptides, right, later into all those amino acids. So it breaks, right, all of them will break. Then we have got amylase, right, name itself is amylase, and it will convert into those maltose. Then for the fat, we have got lipase, lipids, right, lipase, and they will be broken into fatty acids thanks to our pancreas, right? They perform all these things, right? So this is one function. Second, it has got that endocrine function, right? You know it so well, right? It is insulin, and the glucagon, right? Islet of Langerhans, these are the beta cells, these are the alpha cells, both from islet of Langerhans, right? And one more name. Okay. So here it is. This is the histology. Almost the entire pancreas is silently doing, these are the serous acinus, right? These are the serous acinus. They say that it is important to release all those digestive juices, right? So their function is digestive juices. That's what it is done by them. So these are the serous acinus. All these red, right, everywhere. But then there are islet of Langerhans. So I always feel like they are like islands of Langerhans. In between there are like islands, right? Because as such, the name of islets means small, isolated masses. Now they can be divided into two parts. They can be divided into two parts. Two parts. There are few cells which are acidophilic. there are few cells which are basophilic, right? So alpha cells and the beta cells. A for alpha, A for acidophilic, B for beta, so B for basophilic. But basophilic, they are more in number, so almost 80%. Right? And what they do, they secrete insulin. Okay, done. Alpha, acidophilic. Well, they are not as cooperative as beta, right? They want to make things bit complex. So that's why there are two types, alpha 1, alpha 2, or the A1, A2, either way, right? So this alpha 1, it releases this gastrin, right? You remember this gastrin peptide hormone, right? This is that peptide hormone, and he is very much interested in release of that hydrochloric acid HCl secretion, right? And on alpha 2, it is that counter of insulin, glucagon, right? So that's how they both are distributed. Yes, that's the developmental part, right? Very, very easy. Actually, there is only one point for this development. They all develop in the form of buds, right? So everything was fine, right? Liver was forming into that ventral mesogastrium, and then from that tube, there comes those two buds, right? A ventral pancreatic bud and the dorsal pancreatic bud. So it means right from the beginning, they both were right developing separately. But who is he? This ventral pancreatic bud. He always tells that yes, yes, I am special. So that is where uncinate process will be formed from him. Rest of the Sharif pancreas will be from dorsal pancreatic duct, right? Rest is from that. But it is this uncinate process, right, which will be into this. So that's the point which we'll remember. So as it progresses, this is what really happens, right? So that ventral pancreatic duct also, it winds, and then both of them, they unite, they make the entire pancreas. But this uncinate, just to remember, it is from ventral, right? So looks easy, right? So this U can be written like V, right? So it is that ventral, right? Ventral duct, and rest is all from dorsal, right? So we'll write it like, why don't we write it like this? Say, when we say dorsal, right? So rest is from the dorsal duct, so that we don't make mistake. Okay. So with this much, now we are on to the final part, that what can really happen. So these are like developmental anomalies. Just the names, just the name. One, name itself is like annular pancreas. So this annular pancreas, where it forms like a ring around the duodenum, right? Otherwise, the duodenum is giving such a support and the pancreas is developing. But what if this pancreas, it goes and it becomes the murderer, right? So it is like strangulation. So that is what is called as the annular pancreas. And yes, obviously it will lead to what's called as the duodenal obstruction, but nothing to worry, right? This suspense thriller is very rare, right? So usually we won't be watching it much. What we really watch is that accessory pancreatic tissues. So because all these buds, right? They are the buds. They need to unite. Sometimes they don't unite. So then they will be moving into those duodenum or jejunum or ileum, right? At all those places they will be moving. And we need to add one more, Meckel's diverticulum, because as such this Meckel's diverticulum is a problem, right? So he adds it into this pancreatic, because Meckel's diverticulum is telling that okay, I'm not degenerating, right? Vitalointestinal duct will tell okay, I'm not degenerating. So in that case it spoils even the pancreatic tissue. Okay, aja, you also come, right? So that they both are over there. So this is a common phenomena, right, where the Meckel's diverticulum is associated with some accessory pancreatic tissue. Then sometimes our that Versung, right, Versung, as such Versung name is like a warlike name, but sometimes he is very humble, right? When it is humble, right, it tells that okay, Santorani, right, you be the prominent, right? So that means that's where, just correct this spelling, it is Santorini. So this accessory duct is bigger than the main duct, main pancreatic duct, right? So it means it will be opening into the D2, but there the papilla would be bigger. You know, when such names come, actually it becomes much easier to remember. Okay, now for the pancreatitis. Just wanted to add one clinical thing. Whenever there is acute pancreatitis, right, there will be epigastric pain and all those things. But you will go for two things. One is, and this is like serum amylase and the serum lipase, right? You'll go for that. And you'll find that both of them are elevated. Normal values is about say 35 to 40. And when you say that this is normal, and when do you say that they are elevated, that is when it is more than 3 times the upper limit of normal. ULN it is word it is used. It is upper limit of normal. So roughly when it is about 120, it is considered as high. But say out of these two, this lipase is more specific, and at the same time it remains elevated for quite a long duration. So that's why I'm drawing this small graph, right, for both of them, and then we'll go for the CT. This is for amylase, right? Amylase in acute pancreatitis. This would be the graph. This would be the graph. It would rise immediately, almost 2 to 12 hours, right? It will start rising. It will reach to its peak. That's the peak. And this peak is acquired 12 to 72 hours, means 3 days, right? 12 to 72 hours. And then it will start falling, and this amylase will become normal. It will become normal after 3 to 4 days. So after 3 to 4 days, if you go for serum amylase, it will be normal. Now this can be misleading. This is where serum lipase would come into picture, right? That's the reason you will always be relying on serum lipase. Not only that, serum lipase is more specific, right? It is 92% specific. That means if serum lipase is high, treat him like acute pancreatitis, right? So this is for serum lipase. When we'll be discussing medicine, at that point we'll be discussing in depth about why all these changes, right? But at least at this point you must remember this much. Now this is how it will go. It would rise, right? And then it would continue for pretty long. That's like a graph, right? So here the rise, there it was, say, after 2 hours it started rising. So here it is bit late, 4 to 8 hours. The peak is reached, right, in 24 hours. But it will come to normal in about 10 to 14 days. By that time, so you will be handling the patient very properly. So this is the important phase, that after say 3-4 days, when the amylase is normal, lipase is still high. So that's your trump card, right? Okay. Now this is CT scan. The level is L1, right? We'll see systematically. We'll spend good 5 minutes on this so that we understand every component in that order, right? So let's start with this. We'll first watch that. Okay, this is, and I'll put the numbers also. 1, that is vertebral arch, right? So fair enough, this is easy, vertebral arch. Then that is this one, that one would be vertebral canal, and it is looking quite good. None of this intervertebral disc is actually protruding, so there is no intervertebral disc herniation. Things are good, right? Now we move to these organs. Beyond doubt, this one is kidney, right? You know that, right? This is kidney. Then this, I won't insult your intelligence, right? That is liver. If that is liver, so definitely this is not hepatization of gallbladder, right? So this is a good gallbladder, right? Good gallbladder. Fine. So then, which is this big structure? The structure which is so near, yeah, it has to be pancreas, right? So that's the pancreas, right? Then if that is pancreas, so over here, this is, right, so number 7, that is spleen. With spleen, we need to find that which are these structures. The looks itself is telling small bore, right, with so many, say, mucosal folds. They are small intestine. That is jejunum, right? Over here it is jejunum. If that's jejunum, so then which structure is so big, which is over here? Well, such big wide bore structure, it has to be descending colon, right? Let's write it like this, descending colon. And we just can't forget this organ, and that is stomach. So at least now we identify all the structures, right? All the organs. Let's go deep and pick up those vessels also. The easiest to pick, completely round, very beautiful. This one is, that's right, aorta. If that's aorta, can you really see this teda meda a bit, right? Wall is bigger, so that is the partner of aorta, and that is vena cava, IBC, inferior vena cava. So far, things are good, right? But then suddenly we remember that yes, we talked about that from inferior vena cava, what was going out, right? It was like right and left renal veins, right? So that's the vena cava. So it means over here, that is this. This would be the renal vein, right? Which is going from, say, inferior vena cava, right? So that's the, this is 12, so let's put the number 13. So that would be the renal vein. And see, this bigger one which is going, that is also the renal vein. That is also the renal vein. So the only difference, right and left, right? So right renal and the left renal. Done? Yes. See, that is aorta. See, there are good structures, this bigger one. Then there is a smaller one. Then there is another smaller one. Those small structures, they are over there. This one. Now think of. It is at this point when four things. Veins are like assumptions. No, not really. Right? See, I just remove this and you will be able to appreciate. See, now you can see, right? Because see, these are the sections. You might say that, is it so thick? No, not really. Because the plane is like this. So when it goes, say this is, I that's like, right? This is how the veins are going. But if you take a section over here, so yes, they will be looking such thick, right? From khate pite ghar ki. Because the section was taken exactly at the level where they were dividing. So that's why this superb picture, this is actually so good. Say zoom. See so nicely. This is IBC. And here is 1 and here is 2, right? That's how they are going. And yes, we talked about it, that this left one is bigger because IVC is on the right side, right? So it left has to travel for a longer distance to reach on the opposite side. True? Okay. Now you have to really focus a bit, right? This middle one, this one, this is superior mesenteric artery, and this bigger one, this one is superior mesenteric vein, right? And here it is. See, that's how they are, superior mesenteric artery and superior mesenteric vein. Though there is one more structure, that is inferior mesenteric vein, which is seen, but you need to be very clear about, see, can you really see this? Because this is the last structure, right? Say superior mesenteric vein, no doubt about it. Superior mesenteric artery, seen excellent. This one is inferior mesenteric vein, right? But because it is almost, say, merged into it, right? Bit difficult to figure out, but doesn't matter, right? Fine. Say, even if you spot this much, right? A big tap on your back, that it is very good. Rest of the structure, see, these are all the back muscles on in the front. These are all, say, rectus abdominis, etc., right? All these, say, these muscles, this one, right? That is rectus abdominis. And then on the side, say, so nicely seen. Okay, just let me show you on this. So this is, right? So nicely seen. All those over here, rectus abdominis, and these are all surrounding, that is external oblique, internal oblique, transverse abdominis, and these are all, this is like quadratus lumborum, erector spinae, right? All those back muscles. So this would be for your practice. Exactly same image, right? Name of the renal veins are mistaken. Why? Means you mean to say right has become left and left has become right? Is it so? First year guy, it looks difficult to remember. No problems, because at any point of time you have to see these things, so not to worry. And see, should not be a problem about the right and left side, because see, spleen is on left side, so this is left renal vein, right? Liver on the right side. Okay, just a minute, I show you something. Just a minute, right? I just wanted to show that image. See, no confusion. See, this is IVC, right? And the section was at this level, right? Section was at this level, this level. And whenever there is any of the confusion, think it like that left renal vein, right? It has to travel a longer distance because the IVC is situated on the right side, correct? IVC is on the right side. And this is the left renal vein which has to travel a longer distance, right, to reach. Now this is like this, and same thing has become now in a different plane. So now the section, we are just watching this section, okay, and here it is. Here it is. So here is IVC, right? This short distance, and immediately it is going into the kidney, so it has to be the right one, and which is traveling a longer distance, and then it is entering into, so this one would be the left one, right? So that's what we wrote, left renal vein and the right renal vein, right? All right. Okay, so this is for your practice, and that's it for today, right? Thank you so much. And it's saved, and I'll put it into our shared folder. All right, thank you, and see you tomorrow. Bye bye.